Now I'm really delighted to have two people from Kaiser-Permanente come and speak to us. Kaiser has been at the forefront of really providing culturally competent, patient-centered care really throughout the nation. We have Kimberly Fox, who's the director of the Direct Community Benefit Investment, Finance and Compliance for Kaiser-Permanente. She has a psychology degree from the University of Maryland and a Master's of Science in Health Services Administration from Central Michigan University. At Kaiser, she is responsible for a portfolio management of investments for the community that exceeds $80 million a year and includes a charitable health program for the DC, Maryland, and Virginia area. And that has benefited many immigrant families in this community. Dr. Maia McCuiston Jackson is the Physician Director of Multicultural Services at Kaiser-Permanente. She's a practicing pediatrician who received her medical degree from Wayne State University and her residency training from the University of Michigan. She is Spanish-English bilingual and has developed and implemented cultural competency trainings programs for physicians at Kaiser and beyond. Her work as a clinician and in promoting diversity in medicine has been recognized by the National Medical Association, the Washington Post, and her alma mater, Spelman College. So please join me in welcoming both these wonderful people from Kaiser.
Thank you very much for that introduction. Right now I'm focused on at Kaiser-Permanente our charitable health programming. So what we want to do today is to share with you our key programs for charitable health programming that we already provide the community. This will give you a good idea and example of how it can be done. There's many different modalities and ways of serving the underserved and immigrant populations. But I think that when you're partnering with organizations, large organizations like a Kaiser-Permanente or other large organizations out there to convene and collaborate all of your great ideas and make something happen, it's important to understand that they have a mission, and you want to ensure that you are fitting with their mission and that really it's in their DNA. Okay, it's something that it's a moral imperative for them to do. So Kaiser-Permanente's mission is to provide high-quality, affordable healthcare services and to improve the health of our members and the communities we serve. So we feel that what is good for our members is also good for our community. So we like to think of equity, not just equality. What do you have access to? This is where we are in this region. This is important because you have to think about your geography. Where are you? Where are your populations? What are the heat maps of the uninsured? What is their cultural diversity? Who can you serve where? And how you need to tailor your programs. Can you do it universally? Or can you be more specific and targeted? And right now in our region, we serve over 600,000 members. Nationally, we have over 9 million members. So we really try to pride ourselves in learning from this membership and how to help and serve them. So the first thing that we need to do as an organization is understand the community. What is the community health needs assessment? What is important to the community, not to us as an organization? From a strategic perspective, as an organization, the community represents our members as well. They live in the communities that we serve. So of course, some of key areas here: access to care, which is what our charitable health programs focus on, and that target serving immigrant populations. But we also have other areas that are very common, I think, in most health needs assessment. Focus on HIV/AIDS, a focus on maternal and child-infant health, chronic conditions, and the health professional shortage areas where there's just not enough professionals to serve. I'm not going to go through this slide. I simply put it in because it's very interesting. It really talks about the whole region and what are the economic considerations we need to think about. So for example, you can see the different diversity between a Northern Virginia with 64% white and a Prince George's County, 64% African American. Very different needs in this community. Very different income differences and disparities. And everybody, I'm sure, is very familiar with this. These are our determinants of health. So many factors. We understand today as Kaiser-Permanente that direct medical care is really only 10% of your health. So what do we need to do? What do we need to pay attention to as we move forward? And this really is the direction and the wave that we're going in acknowledging this fact. With that said, I just slipped this slide in because to me it's pretty profound. It is unreasonable to expect that people will change their behavior easily when so many forces in social, cultural, and physical environments conspire against such change. Okay? Messaging, communication. Right? These are some of our partners. We have many partners in this region. I myself have over 150 partners in Maryland, Virginia, and DC that I work with in the community. For our health programs, our charitable health programs, I specifically we have some of our partners here today, Healthcare Access Maryland, Casa de Maryland, some of our friends that help us really do this work in the community. So let me just talk a little bit about our care and coverage programs. With the advent of ACA and all of the rules and regulations with that, it was a new day. How do we figure out how to provide charitable care and the constraints and parameters of healthcare reform? There's so many rules to follow. And so right now we have these 3 programs. We have Community Health Access Program, we call CHAP because we love acronyms so much. We have Medicaid, and we have our Medical Care for Children Partnership Program. And we are a primary care provider in that program. Okay, so our CHAP program here is for adults and families, and our Medicaid serves that population in Virginia and Maryland. And our Medical Care for Children Partnership serves children ages 19 and under. And the key here is that these serve vulnerable, low-income populations that have no other access to care and coverage. They can't have any public or private coverages, and today that means there's a lot of coverage, at least that you could sign up for. Whether you can afford it is another conversation. But what is available to you? So basically that leaves us serving immigrants. Now I do have a story to click on here to share from our Medical Care for Children Partnership Program. Do you have? And I will just say our Medical Financial Assistance Program. Within Kaiser-Permanente, we want to ensure that financially there's not a barrier to care. So for our members, if you are below 400% of the federal poverty level, you have, no, it's the other one. You have an opportunity to apply, and we will help you with your copays and cost shares. And that helps to address the product design issues that we're finding in the bronze plan, the catastrophic plan, to help you overcome some of those financial barriers to care. And the other programs that I just mentioned as well, we actually serve immigrants, that population, up to 300% of federal poverty level.
Estaba bien mal. Ella tenía una distrofia en los adenoides y las amígdalas. El doctor decía siempre que la llevaba a cualquier urgente care, la emergencia, que necesitaba operación, pero que necesitaba tener los recursos económicos para poder hacérsela. Aquí en este país la salud es bien cara y no todos tenemos acceso. Fue una feria de salud que hubo en Lorton. Ella muy gentilmente pues me informó del programa de NCCP para los niños. Gracias a Dios, Kaiser-Permanente y el programa de NCCP cubrieron todos los gastos médicos de la operación de mi hija, doctores, enfermeras. Nos trataron especial, un trato especial y nos brindaron toda la ayuda necesaria. El CCP ha ayudado a mis hijos varones con sus examen físico, vacunas, se las pusieron al día y pues el cuidado de sus ojos que fue recomendado por la escuela y pues NCCP ayudó con eso. La verdad que no hay palabras para describir lo que siento, lo agradecida que me siento. Devolverle la salud a un hijo es bien, bien importante. Sentir la cobertura, sentirse apoyado, no uno solo. Cuando yo conocí el programa de NCCP, la vida de mi familia cambió. Gracias Kaiser-Permanente, gracias NCCP por ayudarnos y pensar en personas como nosotros. Gracias.
So that was just one story from our Medical Care for Partnership program. As I said, we are a primary care provider, but our community partner administers and owns the program. And they work with other community partners, specialty care, the hospitals as well. We are not the only provider. I'm going to run out of time. I wanted to include this detail, but I will just share with you that our adult program, CHAP, has at this point 6,900 members. We have at least 1,500, I believe, here in the Baltimore area that we just took on during open enrollment. The Medical Care for Children Partnership, 4,200 members, and right now we have 25,000 Medicaid members. We just started in Medicaid in the last several years, so we are ramping up in that. I will say that it was quite a challenge to create a charitable health program because with the rules under ACA with guaranteed availability, it's very hard to offer a subsidized coverage, and that is what we offer under CHAP. It is a gold medal plan benefit structure with a due subsidy contract that is executed with that. That means their premium is covered, it is zero. We also complement that with a medical financial assistance program to make their copays within our four walls zero. So you see, we had to kind of combine programs to get to some kind of solution that actually provides a product coverage. So it's very tricky these days with healthcare reform. If we had to sell a product that was charitable for this population, we'd have to offer it to everyone. And you can't do that. That's not the spirit of what charitable coverage is all about. We are doing some onboarding activities. So we actually have a welcome kit and we do warm calls and we have a mobile van to reach out to these folks in language, and we're working on a health education fair. And that is to really help onboard these people and get them health literate. And we are having in concept phase of talking about things like transportation programs and interpreter pilots. We do have a mobile health van. It's key to reaching out into the community. It can serve 100 people a day in an 8-hour time period. I do have a short video. I'm not sure if I have time. And then Dr. Jackson will come up. We can play that video. Thank you.
We are going to Waldorf, Maryland, to JC. It's a community center.
The mobile health vehicle is basically a nurse-managed clinic on wheels where we go out into the community and we provide preventive care services, vaccinations, you can get your lab work done. We also help you to manage your blood pressure as well as weight. The mobile vehicle is used for flu clinics. We're out at health fairs. We were featured on the Today Show with the NBC4 health fair. We're out in the community.
Welcome to Mobile Health Vehicle. We're here at JC's today. We have 2 exam rooms. We perform a set of vital signs, blood pressure, heart rate, pulse oximetry, height, weight, body mass index. We access their chart through Health Connect, and any lab work or any notes that the physician has prescribed, I'm able to relay that information to the patient if they are not on kp.org.
We do A1C, coumadin, we do cholesterol. Anything that can be done in the lab, we pretty much can do here. You have some that come every week because the doctor's orders.
We're opening up the services and vaccines that we offer.
Tdap, pneumonia vaccines, and shingles we can provide here on the mobile health van.
We have members who live further away from medical centers, so this is our way of meeting them halfway.
There's a lot of seniors that live down this way, and to drive 10 miles is sometimes too much for them.
This mobile van, we pick it up, we bring it to wherever you are. It just brings the experience and the care to you.
You have a lot of patients that are so thankful that we are here on Tuesdays. It helps a lot.
The mobile health vehicle is definitely one of a kind.
You're enjoying the nice weather out there.
This one is absolutely awesome.
Thanks.
Okay, I've been cut short, so I'm just going to start because I don't have much time. But I want to start off and say I'm happy to be here this afternoon because of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And that's a quote from Martin Luther King Jr. So I'm going to start diversity and inclusion, a moral and business imperative. So what Kimberly talked about a lot was what we were doing for the community and partnerships. What I'm going to tell you is what we are doing for our individual patients. I am over diversity and inclusion for our medical group, and so a lot of what we do is cultural and linguistic services, and we are guided by class standards. And for those of you who are not familiar with them, they're culturally and linguistically appropriate services that are intended to advance health equity, improve quality, and help eliminate healthcare disparities by establishing a blueprint for healthcare organizations. ¿Cuántas personas en este salón pueden hablar en español? Si tú puedes subir su... Gracias. ¿Cuántas personas pueden hablar en inglés? Oh, lo mismo personas, qué bueno. Y voy a hablar muy rapidito, un ratito por el ejercicio y después de estoy terminado voy a explicar qué está haciendo. Who understands English that understand me? Voy a probarlos otra vez. Voy a hacer un ejercicio pequeño. ¿Quién en este salón habla en inglés? Pero estas son las mismas personas que hablan en español. Okay, what I just did was an exercise so you can kind of understand. All I did was say that who can speak English, who can speak Spanish, and say I'm going to do a little exercise. My point is, how does it feel when you come into your doctor's office and someone is talking to you, they're speaking a language you don't understand, you are new to a culture, and all they do when you don't understand is raise their voice. So we are caring with class. So let me start out. So class standards in action. The button's not working. Oh, there it is. Okay, so this talks a little bit about Kaiser-Permanente, and I wanted to just cover briefly that diversity and inclusion is ingrained in everything that we do. And you'll see we have key governing bodies. We have a National Diversity and Inclusion Department is out of Oakland, California. We have a National Diversity and Inclusion Council, which has members of all 8 regions. We talked about workforce demographics, and what I want to say is that Kaiser-Permanente is actually very committed to increasing the pipeline of underrepresented minority physicians, both globally and nationally, but also here. I'm not sure if any of you are familiar with ELAM or MEDIC, but it is a medical school in Cuba that provides free health care training. We actually host those medical students every year and are trying to create a pipeline of those students who are bilingual Spanish to come and work with us. And that's just one example of what we're doing. You see what we do nationally, but regionally we have about 600,000 members, 1,100 physicians that work out of 32 medical centers. And here, this is our physician race breakdown. This just talks, it's an example of culturally competent care. Because we are in the DC, Maryland, and Virginia area, we have a wide variety of patients. We also have a wide variety of physicians to care for those patients. And one of the things that we talk about with culturally competent care is that your physicians actually mirror your patients, which we are fortunate enough to do. And here, these are the number of physicians that we have that speak a language other than English. You see 109 of us actually speak Spanish, which is about 10% of our physicians caring for our patients do actually speak Spanish. These are the class standards. As I said, we are caring with class. These are all 15, so once you've memorized these, I'll go on to the next set. No, I'm joking. So what I wanted to do was point out what we are doing with a few of the class standards to take care of our patients. So standard 1 is provide effective, equitable, understandable, and respectful quality and care services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. The first and foremost thing that we need to do is understand who our patients are. We have a very strong initiative to correct race, ethnicity, and language preference on every single one of our patients. So we know who our patients are, and we can provide them the care that they need that is not only culturally appropriate, but in the language that they prefer to receive their care in. In addition, once we know about our patients, we can also address some of the health disparities. This data allows us to know where our patients are, how many of them are. For example, we have demographics on our medical center. We know there are a large number of El Salvadorian patients speaking Spanish in Prince George's County. Therefore, we have a diabetes education class in Spanish located there. We also have data that shows us that mail order prescriptions, when you receive your prescriptions, mail order pharmacy, you're more likely to get a refill, you are more likely to adhere to your medication, and this allows you to be healthier because you're taking medication. We have a specific initiative for our limited English proficient Spanish-speaking patients to encourage them to use mail order pharmacy. Standard 3, recruit, promote, and support a culturally and linguistically diverse governance, leadership, and workforce that are responsive to the population in the service area. And this has to do mostly with our workforce. For the medical group, when we have a need to hire a physician, because we have this data that we've collected, we know how many Spanish-speaking patients we have in a center. When we have the opportunity to recruit a physician, we try to find someone that is bilingual Spanish-speaking. And we also go one step further. Once you come into the medical group, we don't just take your word for it, we actually test you to make sure that you are qualified to provide care in Spanish to a patient that is not English proficient. And also, we also provide ongoing training in culturally competent care to all of our physicians. So, offer language assistance to individuals who have limited English proficiency and or other communication needs at no cost to them to facilitate timely access to all healthcare and services. So we actually have a vendor who does over-the-phone interpreter services 24 hours a day, 7 days a week for any member-facing encounter. This means physicians, nurses, radiologists, pharmacists, member services. Anytime you have an encounter with a physician, a patient can request to have an interpreter. And there have also been times when I myself, not Spanish speaking, but other patients, I will say, I would prefer you not to use your family member, let's use the interpreter. And it's like a light bulb goes off in their head, and they are so excited that someone has offered this service to them. We are also starting to use video remote interpretation for some of our interpretive services, specifically in pediatric subspecialty care. We have a lot of new patients that are coming on with Medicaid and the Affordable Care Act and our other charitable programs that have complex medical conditions, and they are more comfortable with a video remote as opposed to over the phone. And for those of you who don't know, video remote is you see a screen and the interpreter's on screen seeing the physician and the patient. We also have qualified bilingual staff that are there to assist when they are able to, because these are actually people who have other primary jobs that are called in after they've been through training and are certified to do medical interpreting. Standard 8, provide easy to understand print and multimedia materials and signage in the languages commonly used by the populations in the service area. We talked about this before, that there are different dialects in the Spanish language, so ours is Central America. We have a majority of El Salvadorian patients, so anytime you see a sign that has pertinent information, it will be in both languages, and the dialect has also been selected so that it fits that dialect, We have health materials with multiple things about diabetes, asthma, weight management, and other health issues. We also provide prescriptions in Spanish, and so anytime you come in, the provider can do a prescription in Spanish. They write the prescription, and then after, they put RX in Spanish. Not only does this provide that prescription information for that one time in Spanish, but anytime you come back to get a prescription, all of your prescriptions will be in Spanish. It is in your profile. The information will be in Spanish, as well as all the warnings on that prescription. And the last one I wanted to touch on is our translation process. We have a very high quality translation process. And so what happens is we receive all the materials ourselves. Not only do we translate it, but prior to the translation, we check it for literacy level review. As you know, any patient information should be in a lower grade level. So Kaiser-Permanente has decided in this region we're going to do 8th grade reading level or below. Any information that is submitted to us for translation is checked for literacy level, and then it is sent to translate, it's checked for literacy level prior to being sent for translation. And one part of my job actually is to help our physicians take care of this group of patients, patients that have cultural differences and language differences. And as we know, mental health is something that is taboo in many cultures, specifically in those that have recently migrated to this country and have different cultural beliefs and backgrounds. This is just one example of how we have been able to help our physicians with the PHQ-9, which is the accepted depression screening tool. So if you come to me for your health care, for your primary care visit, I am able to not just ask you, are you depressed, but I'm able to click on a screen and you will see that we can do the PHQ-9 depression in English and in Spanish, print it off and give it to you. And I don't just say, are you depressed? You see the series of questions, you answer them to the best of your knowledge, and then we can discuss on what your results are. Thank you.
Does anybody have any questions?
I don't think I need that though. Is there a capped number of patients that you'll be taking in the Mid-Atlantic area?
A cap total, no.
No cap?
No cap.
Okay. And when they come into your program, we are on Epic, so we get to see the care everywhere.
Exactly.
And it's been eye-opening, and I know a couple other people have spoke to this. People will have Kaiser, or they've been to Hopkins or Mercy or wherever, you know, whatever groups are in the Epic system. And it's been an eye-opening experience for us.
Right.
And I think Mary Jo alluded that there's a lot of misunderstanding about, oh, that's insurance, but that's not my question. My question is, will they get, and I'm familiar with Kaiser, will they get full service Kaiser, or do they go by the gold, silver, bronze?
So they do get full service at Kaiser. And now if you're asking her for a specific, well, I'm a pediatrician, so let me answer the MCCP question. It's just an example, if that's okay. So she said it's primary care, but as Kaiser-Permanente and the medical group has grown, we actually offer all the services that you can receive at Kaiser for all of those patients. So we don't say you can't receive a service, you can't receive a service. So any patient that is with us, as long as that service is available within Kaiser, they can receive that service.
So all of your specialty that you have at Halethorpe, they would be able to access all the specialty care, dental.
So we don't have
ophthalmology.
So yes, ophthalmology. We don't have dentists within Kaiser.
Okay.
So for instance, for MCCP program, there are social workers, and they can kind of help those patients get their services. I'm going to let her kind of answer that.
Well, wait a minute, before you leave. Because you brought me to the next one.
Yes.
So can patients' children sign up without the parents signing up?
For Medicaid, yes.
For the
MCCP? Yes. So, what I didn't get to tell you is, because I'm a pediatrician again, so one of the unique things about MCCP and the patients that I take care of is, while they are citizens, their parents have been hesitant to try to get other forms of insurance for them because their parents themselves are undocumented. So I have a lot of patients in the MCCP program who are not themselves undocumented, but their parents are. And yes, you can apply for that program without your parent having Kaiser-Permanente insurance.
So I'll just answer the coverage question. So with our charitable health programs, we offer for the child program, the MCCP, it's everything within our four walls. And we have quite a bit within our four walls: radiology, laboratory, specialist, pediatrician. We have the works. Ideally, you should not ever have to go outside of our four walls unless you need to go to the hospital. And because we're only a provider, we're not providing a coverage for the Medical Care for Children partnership. We can serve the child only. It's a 19 and under. Now, when you talk about products and services like the Gold Medal Plan is the base plan for our CHAP program, children cannot, we are not able to take a under 18 subscriber. You can't be a subscriber. Okay. So that's for families and children who apply together. They have to be under 300% of the federal poverty level. It is the Gold Medal Plan is the base. So that is the product that we springboard from to provide a coverage plan. So that therefore you get a qualified health plan. So it's very equitable to what other people are getting in the marketplace. It is off exchange, and how we administer that is we have the product, then we have a separate dues subsidy contract, which is the premium, and that allows us to say, okay, here's the gold medal plan, it's got a premium and co-pays, but with a subsidy contract, you can negate the premiums to make them zero, and with the medical financial assistance program award, you can help to waive the co-pays within our four walls to zero. And that's what makes it a zero cost within our four walls program that makes it affordable. So it really has three components. It's a little messy, but with healthcare reform, there was very limited ways in which we could actually execute a program like that and still be in the spirit of healthcare reform and fit into the current structure as the federal law is written today.
Recently, you guys had like different Latino partnerships recruiting people to apply for your program, because now we're here in Kaiser all over the place. But is there a follow-up for those people that sign up? Because a lot of our patients that we had at St. Clair, they now have Kaiser, but they have no idea what to do. They don't know if they can access to a Spanish speaker provider. I mean, you guys have like something after they sign up to take by hand these people and navigate them through your system?
So, okay,
I was going to welcome kit.
Yeah. Well, there's a welcome, but we are actually in the process, and as you know, these programs come on, and sometimes hindsight is 20/20. We actually are hiring people to do that throughout the region. So there's going to be one. There's going to be one at 3 of the centers in Northern Virginia. There's going to be, I know for a fact, there's going to be one in PG County. That process is underway to have someone that is actually a navigator, because well, I would say Kaiser-Permanente is a fantastic system because we have so much and we are truly integrated. It does take a lot of work to get through it and go through it. We also have onboarding, and so maybe that's what you're talking about. They've already been through the onboarding and they need something after.
I can speak, kind of dovetail that. We've had people who have gone to these fairs and have signed up for Kaiser, now have a card, but are plugged into other systems like St. Clair, like Bayview. They're pregnant. Here, we've had women who are 7 months pregnant who come into the clinic and say, oh, I got this card. Suddenly they're ineligible for the program that they were in. And we're saying to them, we can't continue to care for you because now you have insurance, which negates the free charity type care programs that are out there. Mm-hmm. And there's not been things providers don't know what to do with these people, and the patients don't know. I've had a woman whose husband signed the family up. She doesn't know where to go. She's 7 months pregnant. What is she to do? I had a woman the other day who was pregnant, and she pulls out at the end, I got this card, but I don't know what it is. It's her Kaiser card. So the education piece, I was not involved with any of it, so I can't speak to what it was or wasn't. I know from dealing with patients, they don't know anything about anything, and it has really affected a lot of patients negatively because it's kicked them out of where they're. We've had TAP patients who were getting specialty care through different things through TAP. Again, if you have insurance, you can't have TAP. So they come in toting their Kaiser card, boom. They can't get their surgery that they were scheduled for.
Yeah, so
On our end.
I'll say this, that we've done this exercise in mass, and there's lots of learnings, and I hate to say no good deed goes unpunished. There will definitely be those that if you were in a program and had any private or public options available to you in the screening process that was done, theoretically, you should not have been put on the program. But, pregnancy should be a small portion of that. Those instances are something that we should talk offline about and come to some solution about. And actually, everyone that we have signed up has received several things. They have received an onboarding packet, very small, in language. Your first 4 steps, how to get a provider, so these mailings have been done as far as acceptance letters for the program, and we're in the process of sending a warm call to them where they should be able to switch to Spanish and actually talk to a provider. Now, it has not been a perfect process. I think we had an overwhelming response in this region, far more than we had ever anticipated, which was very exciting that we could serve so many people. I mean, 6,900 lives is a good thing. I'm not sure I know any other organization that's actually doing that for the immigrant population. So, we're happy to learn more and do more, but those are 3 things we specifically did to try to onboard them. We're also working with our partners like Casa de Maryland, Baltimore County and City Schools, Talk to Healthcare Access Maryland, about doing a health education fair. So we can take some feedback, and at these health education fairs that we are in the concept and planning phases to try to help, because even if you send them a card with all the numbers on it, even if you send an onboarding package in language, 8th grade, even if you call them, their health literacy issues that are there is they don't understand. What is a primary care? What is a medical home? So we definitely have some challenges, but we have at this point put in the coverage and are open to all kinds of learnings, because I think we're the only one doing this. We don't have friends that we can say, are you offering immigrant populations, qualified health plan coverages? The answer is no, as far as product coverage in compliance with healthcare reform and ACA. So that's where we are. Not perfect, but we're always open to feedback, to doing it better. This is the 2nd year we had to reconstruct this program to deal with ACA. So you're talking about, it's a baby. It's a baby, so we might need some extra diaper changes or something.
Thank you. Thank you so much for the baby. I learned about the program 2 weeks before the close of the open enrollment, and believe me, we outreached many of our TAP patients who might be eligible and thinking about the medication that they would be able to receive. So it is a huge gift. The question. My understanding, and please correct me if I'm wrong, that it's a 2-year program, and what happens after 2 years, and do you plan on opening again in the next open enrollment?
Excuse me. So the program subsidy portion that covers the premiums and copays is up to 24 months. So everyone currently on that program, come December of 2016, they should have an opportunity to recertify. But, I think, as was mentioned, that I helped do the financial portfolio management of over $80 million. So, we make our investments in the community, and we will see. We always like to do as much as we can do and much as is possible to do. So stay tuned. Stay tuned. Again, for this year, we're only offer it during open enrollment because it is a qualified health plan, and it's bound by the rules of healthcare reform, which is just like exchange products are only open during open enrollment. So for this year, we haven't made a determination on that announcement. But for this year, I think we're in a good place.
Hi. First of all, I think it's the most amazing program, honestly. We pushed it as much as we could. I'm from Esperanza Center, especially to people who needed a lot of care. Desiree actually asked a couple of the questions I had, but I have clients that said that they enrolled, but they put them on a waiting list. And so I wasn't really sure what the answer would be to that. So could you clarify that?
Sure. So we did outreach, we did events, and what we've done is, actually, quite frankly, in the very last day after open enrollment was closed, we had an overwhelming response up until that point. So surprisingly, we said, okay, well, we're at our threshold for now, but we do not want to ignore those that applied to do final screening to possibly be accepted. So what it really revealed to us, actually, even nationally, more than any other region, even Southern California, the need that was expressed here was more than Southern California, was shocking. It was shocking. And in California, we have 80,000 child members. So proportionately in this region, we accepted about 4,500 new. We have a total of 6,900. So given that, what we did was we put those people on a wait list because we don't want to lose them, and we still want to work with the community to still try to help meet the need, working with other organizations as best we can. And if we do open in the fall, or we have any other type of program available, not just CHAP, not just MCCP, they will receive priority. They will receive priority.